Hello, everyone. Welcome to another City Solvers VMR. Today we have a great teacher discussing with us, or discussing with me, Dr. Ravi. I have to say it, shout out to Dr. Ravi. He just got a nice award of voluntary teaching, faculty teaching. And I mean, it's a role model for all of us, like here in med education. And as case presenter, we have Dr. Austin, and Peter the cat. And again, I have the pleasure of having met both of them in real life, and they're amazing teachers. And I'm so happy and nervous, I have to say. Do you want to say hello, Dr. Ravi?
Oh yeah, very kind of you, Yaz. I'm just very honored to that you introduced me, and that's so kind of you, the words that you just mentioned. But it's great to be back on this platform after a few weeks, and also to discuss a case with you. So very excited, and we also have the honor of Austin and Lachat. What's the name of your cat, by the way, who'll be presenting a case?
Yes, Peter, the cat will be presenting the case. So I hope you guys can speak cat. But it reminds me of that like ancient Ravi VMR where he talked about a cat or something. Yeah.
Yeah, I was on that case with him. So we had Ariel, who is in veterinary school. So she presented a case of a cat with a hematological disorder. And I'm like, oh my gosh. But you know what's so interesting is the pathophysiology and sort of all the pathology of hematological disease is pretty similar. This big cat actually had some sort of leukemia, if I remember. But yeah, I was like after the VMR, I texted Ravi. I was like, did we just do that?
Right, back in the days when we didn't have that much case presenters, and shout out to the case uh, committee, the case review committee. If anyone here wants to present a case, please go to our website and you'll find a link. It's really fun. I know that I just say that I'm nervous, but it's really, really fun to learn together. So I'm already feeling the time stamp in the YouTube comments in this video. So what if we just jump into the case, Dr. Austin? Austin, sorry.
Sure. Yeah. No, happy to start. And so, yeah, Lara's going to pull up the whiteboard and then we'll get started. And so, yeah, just to begin, the first aliquot this is a person that I saw in the clinic. So this is an entirely outpatient-based case. But this is a 90-year-old gentleman who came in saying that he had left foot redness. And so I'm just going to stop there for you guys to discuss.
Okay, so may I start, Dr. Ravi? Okay, so a 90-year-old male with left foot redness. The first thing that comes to my mind is that foot, does it have pulses? Does he have, is he still having sensation in extremity? Is it painful? And one of the main parameters in outpatient, I love primary care, I love outpatient care, is it red, the tumor, rubor, and pain? And meaning in Spanish, we say if it's swollen, if it's bigger, if it's red, if it hurts, think about prioritize an infection, but also don't forget about the pulses, about the sensations in the limb that can go. If there is any other like intense pain out of proportion, those are my first thoughts. If the redness is demarcated or it's not, so to make a differential between erysipelas and cellulitis. And of course, those will be my first thoughts just by hearing left foot redness. What do you think, Dr. Ravi?
I think you're off to a smashing start, and I love this presentation. It's like I can envision myself just looking at a patient's foot, just the way that Austin has just presented this chief complaint, and then just trying to work through my mental processes. Like, what exactly is this? Is it just a simple manifestation of a primary skin process, or is this a downstream reflection of an internal process or an upstream process? So I have no idea at this point, but definitely I really want to dig into this a little further and see. But I think you pretty much have laid the groundwork of, hey, this could be an inflammatory condition. It could be a primary dermatological condition. Could there be a vascular condition? So sort of going through the layers of the foot and see what could manifest with redness. And then to add to that is there swelling and so on. And I really love the point you made about the pain. If it's extremely painful, there's something sinister that may be going on. But let's move on to the next aliquot and then see what else we have. Back to you, Austin.
Okay, yeah, great start. And so, yeah, for the second aliquot, the last time this patient came to clinic was about 3 months prior, and the patient has dementia and is on home hospice. And so he came to the clinic with his daughter, who helps take care of him and provided most of the history. Basically, she's been noticing that her dad has been kind of twitching more when she's been doing foot care. So either kind of trimming his nails or trying to just moisturize his feet because they tend to get dry. And then has also noticed when her dad kind of stands up out of a chair that it seems to maybe just be bothering him a bit more. And so he has a home hospice team that comes about once a week. And so when they came the previous week, prior to our clinic visit, they had noticed some redness and some swelling of the left foot. And so they actually started him on some antibiotics, cephalexin. But by the time he came to see me, there wasn't really any improvement that they had seen so far. They've been taking the antibiotics for about 5 or so days. As far as they know, there's been no fevers, there's been no chills, there's no known trauma to the foot. And then his only complaint was that his feet always feel cold, but sounds like a long-standing issue for him. Otherwise, he didn't offer anything of concern on his end, as best as he could. So that's the second aliquot.
Okay, so now we see, I missed to mention that another thing that I would have wanted to know is when they started to notice the redness and the time onset. You mentioned that this patient starts to twitch with foot care and standing, which makes me think he might not be able to tell us that it's painful, but the way that he acts or reacts might show us that it is actually. And the fact that an antibiotic does not present improvement, one, is the wrong source, two, it might be the wrong bug, or three, it just might be the wrong antibiotic. So that's another thing. Like I would still try to gather more information about this patient. He doesn't have fevers or chills or recent trauma, although elderly patients, even if they have an infection, they might not present fever or like just a very low. For past medical history, I really like the thoughts in the chat mentioning if this patient has had any cardiovascular issues, diabetes. I would also make a thorough search in the foot to see if there is any point of entry. There is a little pearl I want to share with anybody doing the steps is that if a patient with tinea does not get care, that is a risk factor to present cellulitis since it's a point of entry for other bacteria and present cellulitis and whatnot. So that's a point I would like to make. Sometimes we forget to look in between the toes, around the nails. I'm not discarding infection, but I also taking care, making a point of looking at vascular issues. Something that I missed, Dr. Ravi?
Oh, no, I just love what you've just laid out there. I would actually go and open the door of the clinic for you to go and take care of such patients. So eloquently and masterfully just laid out all the possibilities without even diving deep into esoteria, because you could just discuss so many uncommon causes of such a finding. But I think we have to do our due diligence, look at the foot. What other features now with more elaboration by Austin, we see that there's swelling, there's pain. So we're now more into the inflammatory disorders here, right? This twitching has me a little bothered though, right? Doesn't it? How can you relate twitching? Now, this twitching isn't spontaneous. It's more like with foot care or with standing. What comes to mind? How would you kind of frame that with this problem?
Well, the first thing I thought was like, oh, is it twitching? Is it jerking like myoclonus? Could this be related to a neurological process? Shout out to Valeria, I see her in the room? Or is this there are also bacteria that can cause twitching that affect the neuromuscular junction as well, like the Clostridium family. So that's what I was thinking with twitching. For a moment, I was like, oh God, this is a neuro VMR. But then Austin mentioned that it's with foot care and with standing up. So I'm thinking, well, if this patient is twitching only when handling, that might be a sign of pain, but I will be very observant if this happens, like if it's just a patient sitting there like chilling and it starts twitching, I will think, okay, this might be neurological too. So that's what I made out of this data.
Yeah, wonderful thoughts there. I also agree with you that this twitching is likely. There's pain, there's inflammation, and inflammation can sort of migrate along tendons and other connective tissue under the skin, and maybe this pain is causing this retraction. So it could be a manifestation of pain, and this is the reaction. So this twitching is exacerbated by any movement or any manipulation of the area. So we then have to then come back to the primary process and think about, okay, what could it be? I think that was a wonderful initial management thought or management plan to give antibiotics. And cephalexin is wonderful for somebody from the community with non-purulent cellulitis. See if it resolves. It didn't resolve, so now we need to switch gears and start pondering over, could this be something else? Could this be a cutaneous manifestation of inner disease? Not sure, but I definitely would like to take a look at, say, the history, like you mentioned, diabetes would be wonderful. Then this thought of, hey, the foot gets cold, and what kind of comes to mind with that? What does that do for you in regards to this patient?
Mainly venous issues, like when foot feels cold, that's the main thing I would look at. That the vascularity is compromised, and that's something that honestly for me I would be trying to maybe focus this patient, send him for a Doppler of his limbs, because this can get really bad in very short time, and specifically when it's an elderly patient, I try to be like more careful on that thought. So yeah, like what I mean, I don't see any other thing like ulcers and stuff. So but I would definitely like to know what's going on with the vessels.
Wonderful thought there. The ulcers, right? Your skin, vascular disease, if you have ulcers. So there's usually the cardinal findings of, say, peripheral arterial disease. You have ulcers that are more along the margins of the foot, the digits, and so on. With venous disease, you tend to have peripheral venous disease. You tend to have ulcers that may be along the medial malleolus, because a lot of the pressure along the greater saphenous vein going around the ankle will usually cause, and because you have so much like a column of blood just stagnating there, it can cause breakdown of skin and that ulcer on the medial malleolus. So wonderful pearl there that you brought up. So we're not seeing any of that. At 90 years of age, I mean, I have a lot of patients do kind of, will mention there's some problem with circulation. I would kind of put a pin in it. Could this be something that's a detractor? Should we put a lot of weight on it? I don't know at this point, but the physical exam will be very helpful. And also some insight into the past medical history, see if there's diabetes and so on, which would actually help us make progress as to what's going on here. Back to you, Austin.
Okay, yeah, great, amazing thoughts. And so next, just about the past medical history. So the patient has Alzheimer's dementia, as was mentioned earlier. They have hypertension, and then have a history of type 2 diabetes. The last A1C that we have on file was 5.9, and that was about a year prior to the patient's presentation. They have hypothyroidism, and the last TSH about a year ago was at goal. And then there is a history of neuropathy that his daughter notes, but as far as why they have neuropathy, the extent of it, like any details beyond, it's just the name. There's nothing available, and they're not really sure. They just said they were told that he had neuropathy in the past. The surgical history, nothing really relevant. Family history, nothing relevant. Socially, he's retired. He lives with his wife and daughter who help take care of him. And then for health-related behaviors, he is a never smoker. He enjoys a beer a couple times a month, but nothing extreme. And then no substance use. And then as far as medications goes, he's just taking Tylenol as needed, and then levothyroxine for his thyroid. So I'll stop here and just get your quick thoughts on that.
Thank you for this data. The first thing that came to mind now, now that you mentioned that he has past medical history of neuropathy, is this disease or this entity called Charcot foot or diabetic neuropathic arthropathy. That's like the big fancy name. And basically it caused like, correct me chat if I'm wrong, like this, the bone is destroyed. So there's like this subluxation and there's deformity of ligaments in the foot. So it can present acutely, and it does present with swelling, with warmth, with this, with redness. Although the feet feels cold, so that's throwing me away from virtually all of my differential diagnosis. I think that I would send this patient for an X-ray, and also to see if there is a how do you call it, this rocker bottom deformity that you see in the Charcot foot. That's something that I would add to it. And I mean, he has hypertension, diabetes, hypothyroidism. This definitely will make me ask for a new glucosylated hemoglobin levels, a thyroid panel, to see how his electrolytes are, like point glucose and all those stuff. And again, I'm trying to not anchor on this, but I'm still thinking that this swelling might be an infection. So yeah, I would be very observant on how the warmth and erythema progresses. So yeah, like is there something that I am missing? What do you think, Dr. Ravi?
Oh, I think you're doing a wonderful job there. When looking at the past medical history, system one thinking, you're like, hey, diabetes, high blood pressure, we already kind of hypothesized that this could be causing some sort of complication in the foot. You got vasculopathy. You can also have the neuropathy that Austin had mentioned, but this patient's pretty relatively well controlled. I assume the blood pressure is at goal. The hemoglobin A1C is pretty good. Hypothyroidism, TSH is a target. So whoever is managing this patient is doing a spectacular job. And the neuropathy, though, what's interesting is this related to the diabetes? And you did a wonderful job of bringing up some condition called CMT. At this age, probably not, but it's good. Sometimes you can't help but think about these certain conditions where you can have neuropathy due to that. But then you also have some malformation of the leg, that inverted water ball sign that we always get. So the exam will be very helpful to see if something like that is manifested in this patient. Medications, nothing there that I can think about side effect wise that could cause something like this. There's no trauma history, nothing that happened there. So at this point, I really can't make progress with this. System two thinking, elaborating on it. This past medical history likely doesn't have any bearing on this, although you went back to square one, which I liked. Are we dealing again with an infection before going on to a multi-system disorder? Infection, we also know that diabetes is an immunocompromised state. So could there be some other sort of infection? Now, cellulitis isn't usually highly inflammatory, right? A garden variety cellulitis, distal in the extremity, unless it's complicated, like a purulent cellulitis, like a necrotizing soft tissue infection, that's where laboratory parameters will go out of hand or out of control. So you'll have white count, you'll have elevated lactate, you'll have maybe other hallmarks of inflammation, SED rate, LDH. You may also have hyponatremia in these cases, maybe purinoazotemia. So hallmarks of sepsis in this case. But at this point, I'm not getting the flavor of something like a necrotizing soft tissue infection. The patient's not manifesting with a fever. These antibiotics wouldn't be useful for something like that. In that case, you have to consider a polymicrobial infection. So gram-positive cocci, gram-negative rod, Pseudomonas, and also Clostridium you need to also target. But I'm going to kind of move away from that. I'm exploring the realm of cellulitis, uncomplicated, complicated, and necrotizing skin infections. With diabetes, Pseudomonas you have to consider, but I'm still not getting that flavor of an infection. So I think we need more data, and the exam will be helpful, particularly if there's a fever. If there's no fever, less likely, but let's see what Austin has in store for us with the exam. Back to you, Austin.
Yeah, great thoughts. And then I think Tansu commented in the chat about the diabetes control previously. And unfortunately, we don't have any of that information in our chart. And I'm not the patient's primary care doctor, but as best I could gather from the chart, it's unclear like what their level of diabetes control was in the past. But to move on to the vital signs, the patient was afebrile. The blood pressure was 130 over 63. The pulse was 53, respiratory rate 18, and they were satting 99% on room air, and the BMI was 20. So generally, he was in no acute distress, and he was alert and interactive. Going to his extremity exam, he had no lower extremity edema bilaterally. And then now I'm going to share my screen and show you what I saw on his foot. Okay. Are you guys able to see the screen?
Yep.
Okay.
So Yaz, you want to put your dermatology thinking hat on, and what do you think's going on here?
First of all, I see that it's all red. I do agree that the nails look like onychomycosis, or I mean, this patient doesn't have any past medical history of rheumatological conditions, so that would be prioritizing. Because if Dr. Austin have said, oh, this patient has psoriasis, for example, I will expect like this pitting or like this very fragile nails. But in this case, this patient, that's what I'm looking at, and that the redness is on the whole foot. So the thing is that throwing me out is that in venous insufficiency, we see that the chronic venous stasis can lead to this whole redness, but it presents with warmth and edema. And this patient has the feet feels cold and there is no edema. So I'm thinking, well, what if this is a peripheral arterial disease? But the thing with peripheral arterial disease is that this patient, like the redness, the presence of redness is atypical for pure skin. And I see that the ischemic limbs are often pale. However, they can be like mottling and whatsoever, but this is completely red. So I'm confused in this moment. I'm trying really not to anchor on infectious, but so far I would definitely think on cellulitis. Although, what do you think about the middle finger of this patient? Like, that's the only one that's a little bit more pale. So now I'm a little bit confused. I will look for the pulses and maybe make the ankle brachial index testing if feasible, because I am a little bit puzzled here. What do you think, Dr. Ravi?
Oh, I think you're probably not really puzzled because you said quite a lot of great things there. And I agree. It's kind of, yeah, something curious. The two things that I want to ask Austin, like when you put your hand on it, is it remarkably warm compared to the other foot?
Oh, I will reveal to you in just a little bit.
Oh, okay, okay.
I guess, and then what was your other question?
And also when you press when you manipulate the foot, is it very painful? Does the patient jump out of
Okay,
proportion to
good.
the
Yes.
pressure?
Perfect. Yeah, I'll tell you in just a
Okay.
second. I guess I'll have you comment because this is the best picture I could take in the moment, but I guess I'll direct you to this general area here, if you can see my mouse, where my thumb is pulling on the patient's third digit.
Oh, wonderful. Yeah, yeah. Okay. So, but I kind of was going to comment, the first thing I saw when looking at the foot is the skin looks quite kind of thick, right? So it's thick and sort of leathery. So this process it's not an acute process. It probably has happened over some time. The nails, like Yaz had mentioned, the chat has mentioned correctly, dystrophic, definitely sort of reminds you of possible fungal infection. You know, sometimes what can happen, that can actually irritate the nerves, causing this so-called twitching, which was in the first aliquot. And then the second toe has, maybe I'm reading too much into it, but it's sort of like a depression there. So I don't know if that is, it's not scab-like, but there is an indentation there, which I wonder, and then this kind of like a whitish surrounding to it. But then just what Austin had indicated, interdigit-wise, there is inflammation there. It's not scaly, so it's nothing like tinea pedis, but there's redness there. But just that movement, you notice that, Austin, like you move the toe and then there's this blanching. So this blanching that's happening there, that's kind of, you could say that is something that could be pivotal in this case. So a red foot that is blanching, and I think people have mentioned, like, could this be a venous issue? There's certain things I may have to brainstorm to consider in this case. But I think that may be significant, especially since Austin said, hey, take a look at what I'm doing here with this foot or this toe. What do you think, Yaz? Anything come to mind?
I'm actually thinking about like this. It does look like an ulcer inside of this toe, and I mean, elderly patient does have a weakened immune system, although I'm still wondering if this could also be like vascular compromise, because I'm not saying that it might not be peripheral artery disease. I really agree with the fact that the foot looks shiny and like rubbery. And I mean, the reason it could be red could be the red perfusion state. I don't know, I'm stretching here the diagnosis to fit, so I'm trying to steer away from that. But yeah, I'm thinking that we should prioritize those two. And another thing that I also saw is that his heart rate is 53, but his blood pressure is kind of like there. And so I am also trying to not like to keep that on mind. I'm wondering.
Yeah,
Like if I saw this patient now patient, I would be like, there is something going on here, but I still cannot put my finger on what.
yeah, I think that's a good observation, especially with his age. Certain changes happen, autonomic changes happen. So his resting heart rate, 53 is actually, that's mine. So it's good. So I wonder, a pretty healthy 90-year-old, could this be the onslaught of maybe conduction issues in EKG to see if it's just sinus bradycardia, or is there anything else that's in evolution? And then the diastolic blood pressure here. So his blood pressure is pretty good. You know, we tried ACC, AHA is like saying less than 180, no, sorry, 130 over 80, but he's 130 over 63. So there's some diastolic issue happening here. And when you imagine or you think about a low diastolic pressure, what do you kind of think about? What comes to mind, Yaz, before I kind of tell you what I think?
Basically autonomic issue like dysautonomia, but this patient has hypothyroidism, so that could explain it. That's my first thought, my reflex thought.
Very good. So, you know, when you take the blood pressure, right, the cuff
Mhm.
compresses and you're listening for that chord cuff sound. So you're compressing the vessel. And then the diastole is at the end of systole, what is actually in the vascular tree. So if you have low filling or you have backflow, so you have blood coming out, then there's maybe like a valvulopathy that's happening. So low state in the vasculature, anemia, dehydration, or you could have what's called this wide pulse pressure because of certain conditions, hyperthyroidism, thiamine deficiency, and so on, wet beriberi, and so on. But here, one thing I did want to mention before we move back to Austin, if this was a chronic vascular issue, what do you usually see with patients with long-standing, like edema or peripheral venous disease in the leg? There's certain skin changes that you do see over time.
Yeah, like it looks like hairless and it looks like shiny. Those are the main findings. If there are no ulcers, that's the main thing, like hairless and shiny limb. So
very good. So for arterial disease, that's what you see. With venous disease, you'll see that plus pigmentation changes. So you see the edema, you see the shiny skin as it stretches, and you'll also see deposition of like hemosiderin. So you see browning of the skin or bronzing of the skin, which we don't see in this foot, although we don't see all the way up the leg. But yeah, those are a few thoughts. But let's see, there were 2 questions or 3 questions Austin was going to answer for us. So we'll send it back to Austin.
Yeah, great job. I just wanted you guys to like squeeze as much as you could out of the picture, and you guys did an incredible job. So yeah, just to clarify exactly what I saw in the exam, which you guys pretty much touched on everything. So on the lateral aspect of the left third toe in the web space, there was a ulceration with a clean base. The foot was erythematous and had kind of like a glossy appearance to the level of the metatarsals on that side, and that was different compared to the right side. And those changes improved when I had the patient elevate the leg. And then generally speaking, to Robbie's question, both of the feet were cold to touch. The cap refill was less than 3 seconds, as Ravi picked up on. And then I was unable to palpate a dorsalis pedis or a posterior tibial pulse on either foot. And then to the neurologic exam, it was a little bit challenging with the dementia, but as best we could pick up, he had reduced sensation to pinprick and vibration to at least the level of the mid shin, probably higher. And then he didn't have any Achilles or patellar reflexes that I could detect, though the reflexes were reserved in the upper extremities. And then, as you mentioned, the nails were thickened, but there really wasn't prominent tinea pedis, as you mentioned. And then there was nothing that I did that could reproduce the patient's like twitching or discomfort or pain. I squeezed the foot, I pushed on it, I moved it around. It just, nothing really seemed to bother him or cause pain. So I'll just leave you guys to comment on that real quick, and then we can move on to the next aliquot.
What do you think, Yas? There's a lot to work with here, and I think we can make progress now.
yeah, like now I'm thinking that this reduced sensation to the mid shins, I would expect this patient to not feel that much pain with the neuropathy, by having neuropathy. Something I would ask of the familiars is that how long has he been had diabetes? I would definitely love to correct myself later, but even if we had a controlled hemoglobin, glycosylated hemoglobin, the long evolution onset of diabetes can also give us neuropathy. So independently of the levels of the A1C. So I'm really thinking that this could be something related to that, because again, something arterial was like throwing away all the way that it's presenting, because when Dr. Austin mentioned that when he elevated the improvement, that doesn't happen with peripheral artery disease. Like not only the limb with a peripheral artery disease looks pale or even mottled, as I mentioned, it does not get better with elevation. So that's what's steering me away from something arterial. I'm still thinking maybe looking at X-ray. If this was a patient I was looking in a consult office in Mexico, that's what I would do first, like X-ray, the CBC, during the PE, I would do the monofilament testing. Although Dr. Austin mentioned that he tried to recreate those feeling, the sensation, and he mentioned reduced pinprick. So I'm thinking this is neuropathy, and we should see and evaluate the structure of that foot. What do you think?
Yeah, I think you've done a wonderful walkthrough of peripheral arterial disease and diabetes and just the workup, the monofilament testing and so on. So I think, yeah, the goal here would be definitely strict control, but we're too late for that. Whatever's happened has happened, and now the patient's progressed to now losing pulses, having pain, poikilothermia. I think Reese had maybe gone through the 5 Ps of peripheral arterial disease, so paresthesia. No paralysis though, but although some of the reflexes aren't too good here as well, so they're not elicited. But we're sort of brewing towards some of those Ps, and then could this mean or spell out peripheral arterial disease? So the next order or next test to do to confirm this hypothesis would be what you mentioned, the ankle brachial index. Now it's both sides, and you'd mentioned this elicitation of moving the foot. When the foot is moved up, the erythema subsides. So usually it should be I guess, when the foot is down, it fills, but when the leg is up, it empties. So definitely there's something with the vascular system. Is it PAD or is there something else? That I don't know, but definitely let's see if there's labs. But I'm very interested in imaging and maybe the ABI as well. So how would we image if the patient has or is able to tolerate contrast, doing a CT with contrast of the vessels to make sure? Some people would do a venous duplex also, make sure arterial duplex, venous duplex, get those ABIs as well. And then see if there's any signal in the lab, CBC chemistry as well. Any other ideas, Yaz, before we send the mic back to Austin?
No, definitely. Something I wanted to add here, and that stuck with me since I was an intern back in medical training, was that if you want to send an X-ray and evaluate the whole integrity of the metatarsals and the bones, send an anterior posterior, a medial oblique, and here I owe you this one, but I think it's a lateral projections. So those 3, if you want orthopedic people to be happy with what you ask for. So yeah, those would be like what I would do. And if it's not conclusive, like MRI, but I mean, I don't think this patient has such a big of an infection like soft tissues. It doesn't look like it. And again, thinking a lot about your teachings, and maybe focus this patient, or at least send him to a Doppler test. I'm really curious about how his vasculature is doing here.
Okay, very good. Asking you shall receive. So what I did was just sort of gave them general kind of wound care instructions, and gave them kind of strict return precautions or emergency room precautions. And I ordered an ABI, and we were able to get that done about a week later. And so I'll give you the basic results of that. So on the right leg, the ABI number was 1.76. And it was actually the same on the left leg, 1.76. And then the waveform on the right leg was biphasic, with triphasic being normal. And then on the left leg, it was monophasic. And so I just wanted you guys to comment on that really quickly. And if you don't recall the particular cutoffs, then I have a little bit of I don't remember these either, so I looked it up in the moment. So if you don't have that, that's fine. I'll just teach about that real quick, and then we can discuss what to do next.
I have to say that the step 3 prepared me for this. And I know, and I remember that a cutoff, and please correct me if I'm wrong, if not, I had this wrong. More than 1.4 is the cutoff. And if you have 1.4 on the ABI, that means that it has calcification. It has like a term, but like in my mind is calcification. And you may think that these walls are already too hard, that they are not compressible. So yeah, that's what I remember.
Yeah, I think there's also, say, the ABI, if it's less than 0.9, that could be PAD, but I think you also do this toe brachial index as well to confirm it. I don't remember the value for that, but the ABI is less than or equal to 0.9, and then the toe brachial, I've never done toe brachial, but that would be something to also consider. Regarding the waveform biphasic, that yeah, if you can help us with this, Austin.
Yeah, absolutely. And you guys nailed it. So basically when you have a ABI and you get a number above, there's different cutoffs. If you look, the number that I saw was 1.3 as a cutoff. But as Yaz says, that means there's sort of non-compressible vessels. So you can't actually make an assessment of what the patient's blood flow status is when the vessels are non-compressible. So you need to do another test to assess. And so typically you move to the toe brachial index. And so that was done, and I'll reveal that in just a second. But to the point on the waveform, if you go back to your time, or maybe Ravi yesterday saw someone with an A line, but if you remember in an arterial waveform, you have this like dichrotic notch. And so basically a triphasic waveform is you just have two peaks and one valley. And that's just sort of mimics like what a normal arterial waveform is. And so that's where the triphasic comes from. And as you get progressive vascular disease, then and the vessel becomes more stiff and less pliable, then you lose your dichrotic notch. So then becomes biphasic, and then if the flow is very minimal, then it becomes monophasic. And so that was suggestive in this particular case of that there was peripheral arterial disease that we're missing. And so most labs like protocolize their ABIs in a certain way that you don't have to specifically ask for TBIs, I learned. So, but every institution is like a little bit different. So I would just check and see if you have a high probability of someone having peripheral arterial disease and you get this type of information. I always ask them to do TBIs. And then if it's still normal, then I ask them to do exercise ABIs, so that you don't, it's just like you do with a stress test. You need to stress the legs to reproduce symptoms. But yeah, just a teaching point. So I will share my screen and show what the report looked like, just to have that. Okay, are you able to see my screen? Okay,
Yeah.
perfect.
Yeah.
Yeah, basically here,
It's de-identified, right?
this is de-identified, yes.
Okay. Just want to make sure. Thank you.
Yes, of course. And so, yes, you can see here that 1.76 was that was an ABI reported to you. And actually the way they calculate ABIs is they'll do an ABI with the posterior tibial, and they'll do an ABI with the dorsalis pedis, and whichever value is highest as far as the pressure goes, that's the one that they actually report. And so the one with the dorsalis pedis was actually significantly lower. And you'll see on the left side, actually, it was completely absent. But because of the way they traditionally report, they report it as 1.76. So because of that, they did the TBIs. And if we go down to the bottom picture here with the waveform, you can see that there's a TBI down here, and it was at 0.21, and then on the right leg, and then on the left, it was 0.1. And a normal TBI is basically anything greater than 0.7. And if 0.4 to 0.7 is abnormal, and less than 0.4 is severe. And so the interpretation of the ABIs was that there's moderate to severe occlusive disease on the right leg, and there's severe arterial occlusive disease on the left leg.
Wow. Austin, thank you for that teaching. Yeah, I was trying to sort of cycle my brain. So as far as the ABIs, so if your ABI is less than 0.9, it's PAD. But if your ABI is greater than 1.3, 1.4, then you do the TBI. And the TBI you showed us, if it's less than 0.7, it's PAD in this case. So, okay, I'll try and remember that. Everybody clear? That was great teaching, Austin. Did I have it right? Correct me if I'm wrong.
Yeah, that's correct. And so, I mean, you guys got it. There wasn't anything too exotic about this case. There was certainly some complexities in getting the history, and it's always fascinating to meet patients. And their actual concern was they came in, they were concerned they had a foot infection, and they needed something else. And so, but after looking at the foot and examining it, it became clear pretty quickly that this wasn't an issue, and it was a complicated situation because of the patient was on hospice, and so we kind of went through goals of care. So what happened was I referred the patient to the wound care clinic. And from there, after kind of discussions about what to do, whether to go see vascular surgery at that time or to just try to manage things conservatively, they elected to manage conservatively. But after a month of kind of wound care, unfortunately, things sort of progressed. So I'll just share with you what happened. Okay, can you see?
Wow. So that was the toe where we saw that ulcer, and that's the toe that has become gangrenous. Impressive,
Correct.
yeah.
Yeah. And so basically at that point, they had sent the patient to a podiatrist at that point, and they said, probably we need to amputate the toe, but we need to have you go see a vascular surgeon first. So they went to go see vascular, and the patient ended up having an angiogram. And it showed that he had very severe peroneal artery occlusion, with chronic occlusions with basically no blood flow to the foot whatsoever. And even after they went in and did a couple of balloon angioplasties with some improvement, basically below the ankle, they really couldn't restore much blood flow at all. So unfortunately, in this case, even if they did an amputation, it would be unlikely to heal because he just doesn't have any blood flow to heal. So at this point, they're just managing conservatively, and probably the toe will auto infarct. And if they develop an infection or something like that, then they'll take the patient to the OR, urgently or emergently, but there won't be any sort of planned interventions to care for this. But I really like this case because again, sort of the momentum of infection, we see infection all the time, the sort of complexity of how the patient presented and how they can relate symptoms to us, the overlap of neuropathy and arterial disease and infection and the shared kind of risk factors with that. But then most importantly, the recognition of their arterial disease and what can happen if you don't recognize it. So it's interesting in arterial disease because we sort of classically learn about claudication, but the disease processes, despite using the term peripheral arterial disease, there's sort of two main varieties. One where we have claudication, so it's very much exertional, equivalent to angina. But this case is very analogous to having an MI. And so time is muscle, time is tissue. And so if you ever see a patient with an ulcer and you think it's vascular, that is an emergency, and they need to get seen by a vascular surgeon or an interventional cardiologist or whoever does these procedures at your institution, wherever you work, to address this. In this case, there was more nuance because of the patient's goals of care. But if, let's say, the patient wasn't on hospice and didn't have dementia, I would have completely changed the way that I manage this patient in the moment. But as you can see, that it went from small little ulcer wrapped with a Band-Aid to toe dead in a month. So important to recognize arterial disease. I've missed arterial disease, and I think the main teaching point as well, if there's a really nice Core IM podcast on peripheral arterial disease that I highly recommend, but basically forget the way that you learned about in med school about how PAD presents. Anyone that presents with any type of pain in the leg, whether it's intermittent, constant, whatever it may be, if they have any vascular risk factors whatsoever, just order ABIs. It's a cheap test. and you'll save someone's foot or toe because of it.
Wow, incredible, Austin. This is just I mean, the teaching that you just gave us here is just so important. It's one of the most highly tested topics on board exams, and also in real life. We do see cases. I see a lot more of this acute limb ischemia and emergency. So what you just said is just golden, in that learn to recognize early signs of possible limb ischemia, which is the downstream effect of this. But you really have a remarkable job trying to control risk factors and preventing the progression, especially in our younger population. So there's peripheral arterial disease, amputations, especially in our diabetic population, hypertensive population, smoking population. So controlling those risk factors, you have a very important job, because it actually ends up with loss of limb, loss of productivity, change in lifestyle, recurrent hospitalization because of recurrent infections and so on. So I really applaud you for this case. Just so wonderfully presented, and I really appreciate you bringing the figures to just kind of show us how we should look at the leg like this, and what should we be concentrating on. And I would also suggest everybody to sort of look at the treatment of the risk factors. So controlling the blood pressure, antiplatelet therapy, controlling the diabetes. Nowadays, also including statin therapy as well for such patients. Counseling on smoking cessation is so important. And again, today I'm your number 1 fan, so I really appreciate you bringing this case. It was wonderful. What do you think? Yaz, any reflections on this case?
I think like Dr. Austin mentioned, that we are used to see this on books in med school, how we learn. That was me struggling with like this puzzling presentation of the redness, and it totally flew by me that, yeah, it's not the foot that's the issue. Like, look at the toes too. Like, don't forget that there are 5 toes that you have to looking at, and that's where the ischemia was, like the paleness and everything. So I'm really thankful for this, like the reminder that patients are not textbook presentations, and that we should definitely try to do our best, even if we are outpatient. Our job is to make to prevent this progression and complications, as Dr. Ravi mentioned. Like, I would have sent this patient like CBC and see his cholesterol levels. Like, although this is that I agree with Dr. Ravi that this high intensity statin therapy are given for all PAD patients. But yeah, definitely we'll be reviewing the guidelines, and keep always in mind that the presentation is not always textbook. So thank you so much, Austin. I love these bread and butter cases, and I hope that everyone that's watching will see that they don't have to bring like Dexter syndrome to be able to present, that we also have a lot of fun with this bread and butter cases that, I mean, hopefully I won't see a lot of them, because PAD is scary for patients, but I hope I can treat them the best I can.
Yeah. One reflection point, yes, you know what's interesting? I was kind of looking at the first aliquot, that there's inflammation, kind of the red foot, right? We're thinking cellulitis and so on. And I think, yeah, start with antibiotics and so on. But you know what? This foot was cold. I mean, it's a cold foot. A screaming vascular disorder. And then the foot going up, it's emptying, and the foot going down is filling. So redness. That kind of, I think my takeaway are these maneuvers, and also to listen for the cardinal features of inflammation, which really weren't there, just the redness, right? Nothing else.
Right.
So wonderful. I learned a lot. Thank you, Austin. And we'll turn the mic over to Manal for teaching points. Take it away, Manal.
Thank you, Austin, for bringing such a bread and butter case and wonderful discussion by Dr. Ravi and Yaz. I will start my teaching points with foot redness. That was the main presentation. So whenever a patient presents with foot redness, we have to assess for pulses, sensation, pain, swelling, fever, and the skin temperature, whether it's warm or cold. Then our DDs will be like whether it is inflammatory cause, dermatological, vascular, or it's any orthopedic, like any fracture. Second representation was twitching. You have to assess whether it's on standing or at rest. Then we will consider whether it's neurological cause or inflammatory. In this case, we given the antibiotic to patient, but doesn't improve the complaint. So it may be that we are targeting the wrong pathogen, wrong antibiotic, or it may be a systemic problem. Coming towards the ulcers. So basically 3 types of ulcers we discuss. Diabetic ulcer present on pressure points and usually painless due to neuropathy. And it will appear as punch out with surrounding callus. The venous ulcers are located at medial malleolus and have irregular borders, edema, and hemosiderin staining. It usually improves with the leg elevation as compared to arterial ulcer, which worsens with the leg elevation. The arterial ulcers present on toes, heels, and have well-defined edges, but they present with a very severe pain. Then we discuss about the peripheral arterial diseases. Here, patient will have claudication, weak pulses, extremity will be cold, shiny, and hairless. Then we discuss about this ABI. So if it is less than 0.9, it indicates PAD. If it's greater than 1.3, it's a non-compressible artery, and we require other testing like TPI. Then we have a wonderful discussion by Austin on the waveforms. Like if it is triphasic, it shows normal arterial flow and shows that vessel have a good elasticity and minimal resistance. If it's biphasic, it shows mild to moderate arterial disease with reduced compliance. And if it is monophasic, severe arterial disease with poor perfusion and high ischemic risk. At the end, very important point that whenever a patient presents with an ulcer, just order an ABI. It can be a lifesaver for a patient. And thank you very much.
Thank you so much, friend. I honestly, every single time I hear all of you doing teaching points, I'm like, wow, it's a great abstraction. And this made me sound very intelligent. I mean, Dr. Ravi is already like Master Jedi here, but I feel now more smart. And thank you, Dr. Austin, for this amazing case. I hope you'll have a great, great day. See you. Bye-bye.